Hi, I'm Sandeep. I'm working as a nursing coordinator in Sankalp Center for Pediatric Hematology, Oncology, and BMTU in India. So today I'm going to talk my topic on hemopoietic progenitor cell sources and the collection. So before starting my topic, just I want to give the background of the about the cells. The cell which is come out of the bone marrow, the cell has the different characteristics. The stem cell can be self-renew into another stem cell, also can mature into different cells. In this image, you can see the stem cell is again divided into common myeloid progenitor and common lymphoid progenitor. Again, it's divided into different type of cells and getting matured into basophil, neutrophils, and eosinophil and different cells. So these are the both characters as self-renewal and it can mature into any other cells. So now we'll see the source. So from the where we'll get this cell. So this cell will be richly in the bone marrow. So we can see these cells in the bone marrow. Also, we can see in the peripheral blood also. That is called as a PBSC, peripheral blood stem cells. Also, we can see the rich source of cells in the umbilical cord blood. So these are the three areas where we get these cell sources. So now first we'll see the bone marrow. So generally the bone marrow harvest we are going to do from the donor. Also in during the autologous transplant, we will do it from the patient only. So what are the preparation need before doing this harvest? So first of all, the patient or donor who's undergoing this harvest needs the GCSF. This GCSF is going to stimulate the hormone in the bone marrow and it's going to produce more stem cells. So it will depend again institutional policy and depending on disease condition. So sometimes without GCSF also we may go to do the bone marrow harvest, especially if the donor is sickle carrier. So during that time, so we may not need to give GCSF because some report has reported this GCSF has lead into splenic ruptures. The next thing is the person who is undergoing the harvest need the pre-anesthesia evaluation. He need the fitness from anesthesia department. Also, we have to take the procedural consent for this procedure, and patient has to get to done the few blood investigation like CBC, liver function test, renal function test, and prothrombin, so clotting factors. Also, patient has to get the serology investigations. So once this all the things have done, we have to review the WBC count. So the more WBC counts are very important to get the good rich source of stem cells here. And also the person who is going to procedure need to be in the NBM, nil by month overnight. If the person is going to tomorrow morning is going for harvest means overnight, they have to be in the NBM. Also need to get the part preparation before shifting the to OT. We have to get the part preparation. And as per anesthesia advice, we may need to give the pre-medication. Generally, they will give pre-medication like antacid and antiemetics. And this all the tray preparation is very important. Before shifting, we should have the bone marrow needle. So when we are doing the bone marrow needles, we are thinking of bone marrow. So there are two type of bone marrow needles are there. One is the bone marrow needle have the multiple hole inside a tip of the needle. That is called as a bone marrow harvest. The only single hole which will be there, that is a bone marrow biopsy needle. So here we have to use the bone marrow harvest needle, which will have multiple holes. Also, we need heparin solution to flush the line and flush the syringes. And also we need the collecting bag. Generally we collect in the blood bags. And syringes we need, and we need the transportation bag. And the labels is very important. The procedure, this procedure will be performed in the operation theater. General anesthesia is required. And after patient has underwent the general anesthesia, the patient will be turned into prone position. The procedures, the harvest needle is inserted into the cavity, especially hip bone and the iliac crest. So whenever after inserting the needle, so the withdraw always we have to do in between the 2 to 4 mm. We should not go more than 4 mm. So when we withdraw the stem cell from the syringes, so if we withdraw more amount, 5, 6, 8 ml, like more amount, if we are going to withdraw, we may get more peripheral blood rather than the stem cells. So this is going to, if we get a more peripheral blood, in the peripheral blood, there will be more T cells will be there. So this is going to complicate our harvest. So the patient may get the bad GVHDs. So about this study, in the latest slides I have updated, which we have done study in our center. I will show that one. The next is, there will be several skin punches will happen inside, and also inside the bone also multiple punches will happen when we are doing the harvest. So each time the bone marrow needle will go inside, we will aspirate in the different positions and we will remove it. We will flush that line with the heparin. Again, we will do the procedures. So what is the cell dose required? It depends on the patient size or patient weight. And also it depends on the concentration of HPC in the marrow. Usually the bone marrow harvest will be done in the day 0, and the same day it will be given to patient. If we are not going to give for patient, especially in the autologous transplant, so in that cases, we may require of sometimes cryopreservation. And the cell dose usually depends on the protocol which we have used for the condition regimen, and also is very clearly institution specific. The technique for bone marrow harvest is, the needle will enter inside the iliac crest. We will aspirate the stem cell, quantity is 2 to 4 ml in between, and it will be stored in the blood bag. This is the study which we have done, bone marrow quality index. So you can go through this paper where we have mentioned very clearly about the bone marrow harvest. What are the important steps to be taken? How the harvest will happen? Everything is mentioned here. The next thing I'm going to talk about the apheresis. So apheresis is, again, the preparation is needed where GCSF, depend on GCSF or non-GCSF. And especially when we are doing apheresis, there we need the good venous access, large bore IV access may needed, or sometimes we may need the apheresis catheter. And here also the majorly there won't do not have any anesthesia evaluation or preparation. Mostly we need the CD4, CD3 count and CBC count. Before the procedure, we need to take the procedure consent. The major challenge in the bone marrow and the apheresis, especially in the pediatric patients, we may have a lot of challenge in the bone marrow. So again, multiple pricks we have to do in the punches has to be done in the iliac crest. That will be challenging. Also, there is a challenge in the apheresis, especially in the venous access. So this is the machine, apheresis machine, where the one side the blood will go inside the machine, collection will happen, and the other side the blood is going back to patient. So generally it will be done in the apheresis department. No need of general anesthesia or any anesthesia. Apheresis machine and the apheresis collection kit is important here. And also apheresis team. In the apheresis team, the physician will be there who will have the experience in transfusion medicine. Also, we nurse and technicians required who has the apheresis experience. Once the PBSC is collected, apheresis is called a peripherally blood stem cell. So PBSC, peripheral blood stem cell. So once this is collected from that sample, we require to send the CD4 and the CD3 count. So till reports come back, we can store it in the 2 to 8 degree in the normal blood product refrigerator. The techniques here: outflow, centrifuge, and inflow. So the one tube, the blood will come outside, it will go towards the machine. From the machine, it will collect the stem cells, centrifuge will happen. Again, the red blood cells will go back to the procedural person. So this is the overall review of the apheresis techniques. Next thing, I am going to talk about the umbilical cord. So umbilical cord blood, generally during the delivery, it is treated as a medical waste. The sources, it has the rich source of HPC. But here, whenever it is collected, immediately we are not going to use the patient. It's morely of the safety of the patient. So here we will require to do the cryopreservation of the product. In this chart, I have showed you few comparisons. The difference between comparison between the bone marrow, PBSC, peripheral blood stem cell, also umbilical blood cell. Generally, the typical time frame for the intimation to such the transplantation is in the bone marrow 3 to 6 months, in the PBSC 3 to 6, again in the cord blood is 2 to 4 weeks. The usually collection volume in the BM is 500 to 200 ml, in the PBSC 50 to 300 ml, and in the cord blood 25 to 150 ml it will happen. Adverse effect for donors: there is a risk for wound infection, bleeding, and anesthesia effect. As I mentioned you earlier, as we do multiple punches, there is a chance of getting infection that side, the bleeding may happen, and also the person is undergoing general anesthesia will have the anesthetic effects. In the PBSC, again, the risk is for bleeding. Also, there will be a infection and thrombus. When we are putting the venous access, sometimes the apheresis catheter, especially in the small children's pediatric patient, may need the central catheters, so that all may lead to infection thrombosis. In the cord blood, no need of any access. The next is minimal cell dose for the transplant. The generally in the bone marrow, will you 10 to the power of 8, the minimal cell dose has to be there. In the PBSC, CD34 cell is 2 into 10 to the power of 6 per kg. In the cord blood is 2.5 into 10 to the power 7 per kg. Here the main challenge in cord bloods, we will not have the sufficient volume, especially it may not sufficient to get the sufficient cell dose. Next is red blood cells, especially in the managing the major mismatch, ABO major mismatch. So especially in the bone marrow, we'll have the high source of red blood cells, where it's difficult to directly transfer to patient, will have the effect. So in this situation, we may need to the cell separation. Whenever we are going to do the cell separation, there is a chances of losing the stem cells. In the PBSC, the red blood cells will be lower count, and in the cord blood also. So possibly if we want to give additional dose of cell dose if requirement, we can do again harvest. Also, if the PBSC means, also we can do again second collection. But in the cord blood, it is impossible. And exposure to DMSO. When we are doing the cryopreservation, we are adding a solution is called cryopreservation. So especially in the bone marrow, mostly it will not be there, as we fresh bone marrow we are going to give to patient. And in the PBSC also, mostly we won't do the cryopreservation, directly we are going to do the transfusion. But especially in the cord bloods, every product will be cryopreserved. When we are going to give back to them, there may be chance of DMSO toxicity for patient. And HLA match is required in all of three, but especially most high HLA match is required in the BM and the PBS. Speed neutrophil engraftment will happen. Generally, in the bone marrow, it will take for 3 weeks. In the PBSC, it may take for 2 weeks. And in cord blood, may take 4 weeks. So this is the very drawback in cord blood. It will take long time to get the engraftment. During long time, patient will be long-term neutropenic. The patient may go into infections, especially high risk for the fungal infections. And next is about the speed immune reconstitution. In the bone marrow and in the PBSC, the immune constitution will happen fastly, but in cord blood, it will be slower. Risk of GVHD in the bone marrow will be minimum. In the PBSC will be high source of GVHD. When they collect in the AFAS mission, sometimes mostly when they're collecting the stem cell, it is also collect the T cells. Especially in the peripheral cells, we'll have the mature T cells. Because of this, there will be high risk to get the GVHD in the PBSC. In the cord blood, is a low risk. Next is post-transplant complication. In the BM, it will be low risk. In the PBSC, also low risk. In the cord blood, especially, it will be high. As I mentioned you, it will take long time to engraft because of long duration of neutropenic stage will lead to infections. And next is risk for virus transmissions. In the bone marrow, it will be high risk of risk, and in the PBS also high risk. In the cord blood, it will be lower risk. And CMV reactivation. So in the bone marrow, it will be high. Most donors will have the CMV, they'll have reaction. In the PBSC also has high, but in the cord blood, it will be low risk. So risk for relapse. In the BM, there's a higher rate, and in the cord blood, there's a higher rate. But in the PBSC, there's a lower rate of. So this is all the differentiation between the product, which source is good, which process not much effective. So here in my last slide, the conclusion is HPC collection we discussed. There are 3 sources are there: bone marrow, peripheral blood, and the cord blood. So bone marrow, patient has to undergo the general anesthesia, painful procedure, and also it will have the more RBCs. In the peripheral blood, the patient will not go under the general anesthesia. The required of the big venous access is required, or catheter. And the PBSC will have the rich source of T cell, will have the high risk for the GVHD. But in the PBSC, engraftment will happen fastly. In the cord blood, it's treated as a medical waste. So the collection, always the value will be lower value and the required of cryopreservation. And especially the challenges in the pediatric patients getting the venous accesses, and during harvest also, as we're doing multiple punches, it's very risk to do the pediatric, especially very smaller children. And the important things, what you said, the preparations are very important. In the bone marrow, NPO is required, anesthesia evaluation required, procedural consent, preparation or the investigation. We have to see the CBC value, where hemoglobin and the WBC counts are very important. And in the PBSC, the majorly anesthesia will not be there. The consents will be taken. The collection will happen in the AFRS department, and required of the big bore needles. For cord bloods, there's no major preparation, but during the delivery time, it will be collected from the team of who are specialized for collection, and it will be the cryopreserved and kept. So these are the references where I have gone to prepare my slides. AFCON PBMT material, EBMT handbook, and also the paper bone marrow index quality. And the software which we are using, the BMT Press, a software which is very helpful for us to review the things, what is happening with the patient condition, everything. Also, we have gone to the C2C network manual, Sankalp C2C network manual. Thank you everyone for giving me this opportunity to share